Give me a moment to share.
Yeah, your slides are visible.
Okay, sir.
Go in the full mode actually. Presentation mode. Yeah.
1 second.
No, slides. Here again.
Is the slides visible, sir?
Yeah, slides is visible, but in the presentation mode, yeah, you have that's right.
Okay.
Click on.
So yeah, I'll put up on the presentation mode. So just give me a second.
Okay.
So the thing is, sir, thank you very much for this kind words and very nice introduction, sir. So, what I'm going to present here is, as you can see from the talk, managing the pandemic data. So it is this COVID pandemic where we have witnessed importance of data in managing and mitigating the COVID pandemic. Scientists worldwide have developed a lot of data systems and complex logics and have developed systems for integrating mining of data from these diverse sources. India responded to the pandemic with the development of three important systems: the National COVID-19 Testing Database and the COVID-19 India portal, which captures information about individuals tested, hospitalization, their outcome. And the third one, most important one, is the CoWIN platform, which captures vaccination information. And integrated access to these systems or sources have been used for formulating various policies, implementation guidelines, and monitoring the implementation. I have been associated with COVID-19 data management at different levels and forums since January 2020. So in this presentation, I'll be sharing with you my experiences and the challenges which I feel requires immediate attention and action, not just for this pandemic, but for the pandemics of future to come. Sincerely hope they will not come, but they are inevitable. So please bear with me. So there are 3 slides about my organization. Most of you are aware of it, my division and the activities we are involved in. And after that, I'll start with the pandemic data management. So Indian Council of Medical Research, as most of you know, it's an apex body for formulation and coordination of medical research across India. We do so by our thematic research institutes all across India, as well as focused research programs. Most of you know as fellowship programs, ad hoc projects, or task forces. The division, there are 12 divisions in ICMR, and one of the division is division of Biomedical Informatics, which I'm heading. This division is primarily involved in promoting informatics in medical research. The major activity that we have taken up is development of accessible data systems and integrated research platform. Some of the data systems that my division is involved developing and has developed are listed in this slide. It runs across communicable diseases, non-communicable diseases, and various other areas. Like if you can see 17, we have developed a total IT solution for Jal Jeevan mission of Government of India. In addition, we have also developed this National COVID Testing Data Management System, AMR, Linkage for leprosy data management, so couple of many other systems that my division has developed. So now after this slide, so let's come to what is pandemic. So if we look at the definition of pandemic, a pandemic is defined as a disease which spreads across different continents and affects large number of people. So if we go by this definition, which is defined by the WHO, and come to COVID, how a pandemic can be controlled and managed. Pandemic can be controlled by formulating data-backed policies, programs, and guidelines, which we have seen in COVID. It can be controlled by monitoring and evaluation of the policies and programs. Further, we need to work on developing better diagnostics and therapies. Samir sir was telling that we need to focus on tracking and tracing, but we also need to focus on better diagnostics, because diagnostics is the area which helps in tracing and tracking. We also need to work on large scale surveillance and contact tracing. So all these, what requires is structure, management, and integrated analysis of data from various sources. What are the various sources? If you look at COVID from India, the primary data sources are data from surveillance, laboratories, and hospital information systems, some of which I have mentioned here. And then there are secondary data sources. We have transport systems, we have mobile networks, and we have social networks. Number of applications which are developed for tracking, contact tracing, they used integrated access to all these systems. Now, what advantages this integrated mining of data sources can give us? It will help in identification of outbreaks, understanding the disease spread and etiology. In fact, each of these points I have seen with my own eyes happening in COVID. Identifying hotspots and marking containment zones, contact tracing, identifying vulnerable groups in the population, guidelines, and then developing models for predictive analysis, and then many more. So if you look at COVID, the primary data sources, there are 4 primary data sources which right now exists. One is this testing data source, testing data management system, which captures information about individuals who got tested for COVID-19 and what was their outcome, and then location and all. COVID-19 India portal, which captures information about people who become positive, their outcome, hospitalization, and other hospital infrastructure requirements. CoWIN platform, which all of you know, captures information about vaccination, and INSACOG, which captures information about the genetic makeup or the variation or the sequence of the virus. So it is, I would say that it is very interesting because we have a direct connection with the INSACOG, because all the sequences which are entered into INSACOG, they have a SRF ID or the specimen referral form ID from which you can connect to the COVID-19 portal and the testing portal. So in addition to primary data systems, there are approximately 62 secondary data systems which are primarily used for contact tracing, quarantine monitoring, COVID-19 health related information, essential services related information, and more. So coming to this COVID-19 testing data system which we have developed, it started with the SRF form, development of a SRF form in somewhere in January 2020, the specimen referral form by ICMR's NIV Institute. This SRF form, the entire system is based on this SRF form. It has been updated 17 times since past 1.5 years based on the recommendations of expert group. There is a app developed by NIC which captures this information as well. You must have heard of this app. It's called RT-PCR app. This RT-PCR app facilitates sample collection. Now, how the data flows in the COVID-19 testing database. The data is captured from 2 different ways. One is browser-based data submission, and second is the API-based data push. There are 9 states which are pushing data through API. So what they are doing is they are collecting data from their all testing laboratories in a centralized state level application. And then from there, they push data to ICMR database. And the rest of the states, they are submitting, all the laboratories from those states are submitting data through web browsers. So this database in ICMR system is then disseminated in 3 ways. We are pushing API-based dissemination to various national agencies like NDMA, Ministry of Health, and we are also pushing data to various state war rooms. And recently, we have also integrated with the A-Suvidha portal at the airport, with the airport authority, where the testing results can be directly fed into the A-Suvidha portal. Second way of dissemination is role-based dashboards, which we have provided to states, districts, and various government organizations. Third, very recent addition is citizen-centric service, which we have launched. It is, in the next slide, I'll show you. So it generates QR coded report, and any citizen can download its report from the ICMR system. Yeah, so this is the third facility that we have launched. So one can access this facility at report.icmr.org.in, and the data that this report provides is basically the basic parameters which are as per European Union standards, ICAO standards, and WHO is in the process of formulating standards, but we are in close contact, and the report will be as per compliance to the WHO standards as well. The QR code which is generated is similar to what CoWIN generates using the same technology, and one can use a public key to develop apps for verification. So this is a huge service which people are using to download and verify their reports. One glimpse of the dashboards that state level and district level and national level dashboards that we have developed. It does all sorts of analysis, not just positives and samples tested, but it also does stat analysis, kit-wise usage, lab infrastructure. So a lot of information we are capturing here. Now this is a very important slide. So as I said that there are three systems, major systems: CoWIN, National COVID-19 Testing Database, and the COVID-19 India portal. How these three systems are linked? As I said, National COVID-19 Testing Database and COVID-19 India portal, they are linked through ICMR ID. So there is one-on-one linkage. So there is no problem. But with the CoWIN, there is no such facility of a single identifier, which is common in both the systems. So what we are trying, in fact, we have achieved partially success, is using mobile number. You can think of Aadhaar number, but when we looked at the data sets, there are only 10% of the individuals who have given Aadhaar number in both CoWIN and National COVID test. So what we are now looking at is the composite key, keeping mobile number and the name, and using various methods to put up a probable match between CoWIN and ICMR testing database. So this is one area I think where a lot of work has to be done. And this integrated access to COVID-19 data is being used, as I said in the beginning, identification of outbreaks. And in addition, we have recently put up a vaccine efficacy dashboard, where using the data that is integrated data, we have developed a vaccine efficacy dashboard, and we are also developed breakthrough infections dashboard for various departments of the Government of India. Now, these are some of the publications which highlights the work that we have done in COVID-19, and probably you can find this publication on ICMR website as well. Now, coming back to the definition of pandemic. So as I said, pandemic, as WHO says, pandemic is a disease which runs across different countries and affects large volume of population. COVID is not just one such disease. There are a lot of pandemics. Cancer, say for example, one. Another very important pandemic which is going on is antimicrobial resistance, where some work has been done in terms of data, but a lot of work remains. The paper which I mentioned, the 2021 paper, it says that during COVID-19, there is a sharp rise in antimicrobial resistance. So this is one problem that needs attention. WHO in its global action plan outlined 5 major strategic objectives to control AMR. And one of the objectives is development of a national action plan. So in response to this WHO's global action plan, 63 countries submitted national action plan. And among that, India was also submitted. If you look at the international picture on AMR, there are national surveillance systems spread across various countries, and India is quite favorable because we have functional national AMR system. But if you go further deep, in animals, plants, and environments, the picture is not that good. If you go further deep, national monitoring system for consumption and rational use of antimicrobials in human health, there is no national plan. So you can very clearly see that very few work, little work has been done in AMR, and lot of work remains to be done. So ICMR in 2013 started this ICMR Antimicrobial Resistance Surveillance Network. It started with 4 tertiary care hospitals, and now we have gone to 29 tertiary care hospitals where data is being collected, and for 6 different group of pathogens, which covers 90% of the W priority pathogens. Now, since I'll be talking from the data perspective, management and analysis of this data, there are challenges because data is coming in diverse formats and from different sources, and there are very few public domain softwares which captures resistance and consumption surveillance. What we have developed and we are in the process of developing is a solution for integrated data collection and analysis, and are proposing standardizations for molecular surveillance and interoperable standards. That's we are working on. One system that we have developed, which is being used in ICMR AMR surveillance network, is a web-based system, and we are also, because people who are working in AMR, they know that WHO has a system that's called WHONET. So WHONET system is being used in large number of countries. So what we have done is using the same WHONET look and feel and the logic, we have developed a Python-based system which works exactly similar but has advantages that it works across different operating systems, and second, it has good API-based communication with the servers. So because in WHONET the problem was of keeping the standards or uniformity across the network, but with this system you can keep the uniformity as well as you can give flexibility to the hospitals for introducing their own antibiotics and their own tests. So if you look at the picture in India, that's what I was saying, that some work has been done, lot of work remains. There are 3 networks which are working in India, primarily major networks. One is by NCDC, who uses WHONET. Second is by AIIMS, who have developed a customized web-based application. This AIIMS network is primarily focused on ICUs, and the ICMR network, which captures data. So there is an API-based integration proposed between ICMR and AIIMS network, and a web-based solution and a standalone solution for the ICMR network. So, but lot of work requires to be done to integrate all these 3 different data sources. These are some of the publications that we have worked in this area. So I have discussed 2 pandemics, COVID and the AMR, which requires substantial work in terms of data integration. Third pandemic, which is going on and across, and in fact it has been written on the internet. Many experts believe that the 4th wave of COVID epidemic will be mental health problems. So ICMR initiated this task force of capacity building in mental health for National Mental Health Program, which has finished in September this year. And we are in talks with the ministry to take the outcome of this task force and implement in the ministry National Mental Health Program. So here in this task force, we collected data on 6 different groups, as you can see. And there are there are 12 implementation projects which were sanctioned, 5 multi-centric and 7 single site projects. And within this project, we digitized 93 scales or instruments in the area of mental health. We tried harmonization of vocabulary across different scales, and developing role-based access analytic models. So how we have developed is, we discussed with the PIs, had a lot of meetings with the mental health experts and different centers, and come up with this application, which is based on the DHIS2. It is a platform used for developing data capturing applications. So these are various scales that we have digitized for various areas in mental health. And what is the system architecture? So what we have done is, we have digitized individual scales as separate entities. So for each of the project, all these scales are called, and then they are put up as different projects. So this is what, it's a modular architecture. So if more scales needs to be added, they can be added very easily. So if you look at, I talked about 3 kinds of pandemics, and from the data perspective, if you look at the government's views on data capture, what we are looking at is a federated integrated health information architecture, where information from different sources is captured at one location, and collaboration with private sector for metadata and data standards and EHR standards. So this is what from the government perspective we are looking at. From the ICMR perspective, we are generating a lot of data from various programs, and this data needs to be made available to the researchers in a ready to use and in a kind of a easily accessible format. So what we have done from the ICMR perspective, we have put up a ICMR strategic plan and agenda document, wherein there are 3 objectives. One is to develop and implement ICMR's policy for sharing and access, which Samir sir was talking about. There is a lot of work that needs to be done for sharing and access of medical data, particularly health data. So there are policies. There is a policy of National Data Sharing and Access Policy. There is a policy from DBT. So there are policies, and then there is this PRIDE program, which has been recently launched. But still there are few areas which needs to be worked around. And then to set up disease and specific and thematic repositories and warehouses, and to promote those warehouses. Like the one we have put up a recent call for researchers to use ICMR's COVID-19 testing database. So the similar kind of work we'll be doing as per this vision document. So this integrated research data platform that is envisaged in the vision document, we have put up in 3 phases. Phase 1 is over, where we have developed the SOPs for data coordinators, nominated from each ICMR institute 1 data coordinator who will look at the data sources from its own institute as well as the regional medical research institutes. First round of cataloging of data sources is complete, and data management plan is being developed and is being piloted in our division, Biomedical Informatics Center, Biomedical Informatics Division. Phase 2 involves developing the policy, for which we have constituted a committee, and probably next to next week we are going to have this meeting. And then we have to also work on metadata standardization and controlled vocabulary. This is just a glimpse of approximately 1,800 responses that we got on cataloging the data sources. The challenges that we saw when we did this cataloging was, first was the diversity. Second is the access to these data sources. Third major challenge is integration. Fourth one is the policy. And fifth one is development of research platform. So now a little bit, I'm digressing from the theme of pandemic data sources and to the data collection architecture that is being used and being promoted. And this is my own thought. So what the government of India is putting up federated architecture, it digress a little. This is the data system architecture that we see in 90s, where different sites are communicating with each other through FTP or through physical file transfers or through ATPs. And then in 2000, we started seeing this client server architecture where sites are submitting data to a centralized database. Somewhere in 2010, we started seeing API-based integration because different sites have their own system. So we'll put up API on top of it, and that API can communicate with the selected fields through a centralized database. But again, the data is being collected at a centralized location. What we are developing right now with the AMR is this, where the centralized site is totally gone. All the sites are communicating with each other. And as centralized, we have an API which communicate with all the sites and then get the integrated access. So this is what we are working on with the AMR system, the Python-based platform that I have just mentioned. So I would like to conclude that we thought that, as Sir said, that a lot of work has not been done in other areas. We have developed vaccine in just 1 year in COVID, and we have not been able to develop vaccine for other diseases which have been present for a long time. But I would like to end up in a positive note that COVID pandemic has shown that if we work together, if we decide, the pandemic can be controlled very easily. And there are many areas that needs the same kind of strong and strengthened effort to control the pandemics. So let's work on the challenges and work on controlling the pandemics. Thank you. Thank you, sir.
Thank you, Harpreet, for the excellent lecture. So if anyone have any question?
No, sir, there are no questions in the Q&A or in the chat.
सुमित, उसमें क्वेश्चन चैट में है कोई क्वेश्चन?
नहीं सर, कोई चैट में क्वेश्चन नहीं है सर.
Okay, no problem. Thank you very much, Harpreet, to join this meeting actually and talking about the ICMR plan.